WFNZ.
Live from Studio A at the Cumulus Broadcast House, it's Health View with your host, Dr. Angela Ruff. Your information leader for more than 65 years. News Talk 640.
WFNZ.
Good morning and welcome to Health View. This is Dr. Angela Ruff, and our guest this morning is Dr. Wendy Jones, who is an obstetrician and gynecologist at Women's Wellness Center. She has been in private practice in Fayetteville for the past 2.5 years. She's a graduate of East Carolina University and East Carolina School of Medicine, and she completed her residency in OB/GYN at Pitt County Memorial Hospital. She is married and has 2 young children, ages 4 and 9 months. Her interests include adolescent gynecology and high-risk obstetrics. Thank you, Dr. Jones, for joining us.
Thank you for having me, Dr. Ruff.
I appreciate it. Well, this morning I thought, we could talk a little bit about some complications, some risks associated with advanced maternal aged women who are expecting.
Wonderful.
So in that, I guess the description of that I just learned today is if you're 35 at the time of delivery. And so, some of the complications that can happen with advanced aged women who are expecting can be, what are the problems you hear about? Chromosomal problems, Down syndrome. What is the real risk of that?
There is a risk with advanced maternal age that increases for having an infant that has a genetic defect such as Down syndrome. Mm-hmm. With advancing age, that risk begins to increase. If you look at 1,000 live births among 25-year-old women, mm-hmm. On average, 2 of those 1,000 births would have a baby that was affected by a genetic syndrome. If you looked at 35-year-old women, 1,000 live births of 35-year-old women, 5 of those per 1,000. So that risk goes up to 5 per 1,000. And then if you look at 45-year-old women, that risk is about 48 per 1,000.
Wow.
So that's a significant jump.
Certainly.
But certainly you can still have a healthy pregnancy and be advanced maternal age with the right care.
Sure. So I'm sure there's some tests that can be done to hopefully find out if you do have a chromosomal problem with the fetus. Can you tell us maybe a little bit about those tests?
Certainly. Some of the more traditional things that have been done between 16 and 18 weeks of pregnancy, there is a blood test. It's typically known as an alpha-fetal protein test, mm-hmm. Or now called a quad screen. That is a blood test that is drawn from the mom at 16 to 18 weeks gestation, and that will indicate women that may be at higher risk for having either a baby with Down syndrome or another genetic problem such as trisomy 18 or spina bifida. That is merely a screening test, and it is not diagnostic of having an infant that has a problem like that. Other tests that can be done are ultrasounds, and typically in our practice we would do a anatomy ultrasound at about 16 to 18 weeks gestation. Mm-hmm. Most of the time, if there is a genetic syndrome, there will be some marker that will be detected on ultrasound mm-hmm. That will be picked up. Some of the newer things that are available are there is also a first trimester test that has just come about in the last few years mm-hmm. That we have started to implement in Fayetteville that can be done earlier in pregnancy so that moms can find out at the end of their first trimester rather than waiting until their second trimester.
Right.
And those are some newer things that have come about recently.
Okay. What about, I've heard pros and cons with, I guess it's amniocentesis. What is your opinion or your practice's opinion on that?
Certainly. all of our patients that are advanced maternal age are counseled about their specific age-related risk. They are all referred to a maternal fetal medicine specialist in town. He's basically a high-risk obstetrician, and he does a very complete ultrasound, and he tells them specifically about their age-related risk. If their ultrasound is completely normal, then frequently that will lower their age-related risk, and they will be counseled about whether they would like to have an amniocentesis or whether they would not like to have that done. The risk of an amniocentesis of a complication is about 1 in every 200 of those procedures that are performed. Should I talk about what an amniocentesis is?
Absolutely.
Sure. An amniocentesis involves placing a needle through the maternal abdomen into the uterine cavity and removing some amniotic fluid from around the fetus. If you can think of it almost as your bath water. If you were in the bathtub, your skin cells are sloughed off into that bath water. And the same thing happens with fetal cells. And so when you draw that amniotic fluid out, there are fetal cells that are floating in that amniotic fluid. And the chromosomes are able to be grown from those fetal cells, and you can tell with a 99% accuracy whether there's a genetic problem.
Wow. So why would somebody not want to have that done?
Because of the risk of the procedure being 1 in 200. And frequently, if you're, say, your age-related risk and your ultrasound is normal, your risk of having an affected child may be less than that 1 in 200 risk. It may be that your risk is 1 in 400, and so you say, well, it'd be more of a risk to actually have the procedure done.
I see. So if the risk then is that they may miscarry?
They may miscarry or
see.
have some other complication. Their water could break with the procedure.
Yeah. Well, it sounds like some of the newer methods out there that may be a safer way to check.
It is.
Yeah. So, women, is there a difference in how long it takes to get pregnant if someone's trying to get pregnant, say they're in their early 40s versus in their 20s?
Certainly. As you begin even your early 30s, your fertility begins to diminish. Now, there's no specific age at which you're infertile, and for every specific person that would vary. But with time, even beginning in your early 30s, your fertility does diminish.
I see. So if you are, say, over 35, what are the chances that you may have a multiple pregnancy, multiple gestation?
If you're over 35 and you've had difficulty conceiving and you're on some type of fertility treatments, perhaps you're taking a medication called Clomid that would improve your chances of ovulation, then if you're on a medication like that, your risk of a multiple gestation is about 7 to 8%. If you are not on those medications, then your ovulation may be somewhat different. And you may ovulate, you may have two ovum that are released at the same time. So there may be a slight increased risk of multiple gestation in patients that are advanced maternal age.
Now, the medication to help these women get pregnant, I've talked to somebody that went through this, that they actually had, they would have been in People magazine if they had all the babies that they were ended up being pregnant with. So they actually had to select out some of the fertilized eggs and kind of do it that way just for the safety of the mother. Is that kind of a common problem when somebody is on that medication?
Not typically. In our practice, we tend to use lower doses of that medication. If you're on higher doses of that medication, or if you're on other fertility-boosting drugs or under the care of a reproductive endocrinologist, sometimes you can have what we call overstimulation and have multiple embryos that are produced from that.
Right. Just during lunch today, I was discussing with one of our ladies at the office, and she was telling me about her cousin who they weren't able to have a boy child, and so she bought some book that was going to help her figure out to have a boy child. And she just wouldn't believe her when she says, really, women don't decide that. It's in the man's genes that decide if it's going to be a boy or girl.
It is. It's all his fault.
But she read that book, and lo and behold, they had a boy. So she swore it was whatever it was she tried.
Of the book. That's right.
It was because of that book. If only King Henry VIII understood that,
That's
he
right.
wouldn't have maybe beheaded so many wives. But I guess the women control the number of kids, or the multiple if they have twins or whatnot. That's more in their control.
Not necessarily, because that egg can divide after fertilization, and you can also have two sperm that fertilize.
Wow.
An egg and split.
So you can have multiples potentially. Well, maybe if you could maybe just talk a little bit about sometimes, I guess, not just women who are over 35, but women who are even younger could get gestational diabetes. Maybe you can just talk a little bit about that and some things that maybe people could try to avoid that.
Sure. Gestational diabetes is diabetes that occurs during pregnancy. We screen all pregnant women during their pregnancy for gestational diabetes. Typically, we would do that at 28 weeks gestation. Mm-hmm. And that is a condition that's very prevalent in our population because of our Eastern North Carolina diets.
Right. We like that Southern food.
That's right. We do like that Southern food. And frequently, if someone has risk factors for gestational diabetes, we will screen them even earlier in their pregnancy, say at the beginning when they first present. Mm-hmm. Risk factors for gestational diabetes would be a family history of diabetes, which most of us have,
right?
Morbid obesity, mm-hmm. Or having had gestational diabetes with a previous pregnancy makes mm-hmm. you more at risk for that in the future.
Mm-hmm. Okay. Well, typically with this, once they have delivered their baby, does this clear up on its own?
Most of the time, it will clear up on its own after delivery. If it is someone that we've picked up at the beginning of their pregnancy rather than in the middle of their pregnancy, it may be that they have underlying diabetes and they just unfortunately were never diagnosed with that.
Right.
And so if that's the case, it would be important for them to continue a diabetic diet,
right.
Even after delivery.
I see.
But that's something frequently because, unfortunately, a lot of us don't get the health care that we need to all the time. A lot of times we will come in when we're pregnant, and if that happens, it will be picked up at that time.
Right, right. Well, tell me, with some of the ladies who were talking at work, some women, even if they seem to be a healthy weight now, some women are able to kind of still look like they haven't had a kid, They're able to, and then some women, in spite of them working out a bunch, boy, they seems like they need a plastic surgeon to make it ever look like that again. What's the trick?
I think that there are several tricks to that, if we can call them tricks. One would be to make sure that you try and maintain a healthy weight gain during your pregnancy. It used to be that doctors would recommend, or the old wives' tale was that you needed to eat for two. You don't need to do that. Most of us are already a healthy weight, or most of us are actually overweight.
Right.
And so if that's the case, if you are already obese, it may be that you don't have to have particularly any weight gain in pregnancy, as long as we know that the fetus is growing properly.
Right.
On average, for an average weight person, a healthy weight gain would be between 25 and 35 pounds with pregnancy.
And that's if they weren't already overweight before they conceived.
Absolutely.
Okay.
Absolutely. And one other thing that would help would be having an active lifestyle while you're pregnant.
I see.
And that would help to keep that weight off and help keep you in shape for your labor.
Right. Okay. Well, good. news. You don't have to have as, quote, healthy a diet or eat as healthy in the quantity sense when I'm going to ask you a few more questions after we take this break.
Okay.
And you're listening to Health View. This is Dr. Angela Ruff. And again, our guest this morning is Dr. Wendy Jones.